I'm going to talk very, basic things about coronary angiography and talk about why to use it, how to use it, and then particularly pitfalls in using it, and then show a little bit of physiology and imaging. So there's a fair amount of time, but hopefully this will be useful content for not just those that are trying to learn, but those who've also learned, and to hopefully consolidate the education in that way. I just want to start by saying that, coronary angiography is basically the fundamental thing that we do in the cardiac catheterization laboratory. And for the diagnosis and management of patients, it's not just about PCI. At least in the United States, many operators and interventional fellows are really focused on the interventional portion. But the diagnostic portion of a cath and a coronary angiogram is probably the most important part of it, because it really helps you determine how to treat the patient best and most effectively. The other aspect of this is that it's really important to get it right, because it's not just about symptoms. There's a lot of people out there who say for stable patients, what we're trying to do primarily is to impact their symptoms, and that's true. But also for severe disease, left main disease, there have been cases across the way in Hall A looking at this. Three vessel disease, proximal LAD, these things are prognostically important. So if we get it wrong, then that can have deleterious consequences for the patients and their lives and their livelihood. So it's not just about symptoms. The other reason that angiography is so important is that in all clinical trials that have looked at strategies of revascularization versus medical therapy, different types of revascularization, surgery versus PCI, the angiogram has been the basic arbiter of risk. And so trials like Courage, Berry 2D, Orbita, even the ischemia trial have based their triage strategy of how patients get one therapy versus another on angiography alone. And so if we don't do an angiogram, and that includes CTA, which I think is a very useful test, how do we know the patient doesn't have prognostically important disease? So if a patient comes in with some symptoms and you do a stress test and they have some mild inferior ischemia, how do you know that that patient doesn't have a left main in addition to a tight RCA? You don't, and so in general, most strategies, at least in clinical trials, have employed a way of looking at the angiogram first to prognosticate risk, and then treatment secondarily after that initial determination is made. For trainees, I think it's really important to remember, and I emphasized this point before, that the cardiac cath lab does not always equal a stent. So many people think that the reason you go to the cath lab is to get a stent, and that's not true. Some people go to the cath lab and they end up with stents because it was thought to be appropriate, but most people go to the cath lab to try to figure out why they're having the symptoms they're having, or the abnormalities in their stress testing, or other things that can impact their prognosis. So remember, we have to be a clinician first and a technician second. That's really, really important. There are other things that we can do in the cath lab besides angiography. We can look at hemodynamics, we can do left ventriculography, we can do shunt runs, we can do aortography. There are many things that can be done in the cath lab, and historically speaking, those things came before coronary angiography. You'll remember that coronary angiography happened by accident. This was something where people were doing hemodynamic studies first, and then by chance injected the left main and saw an angiogram. And I think that's important to go back to your roots to remember that those other aspects of what we do are perhaps equally as important for patients. Why angiography is an art, though, is because of this. It's a three-dimensional structure that moves, and we're trying to project it in two views. So this is a video that looks at all the different views, but you can appreciate how the anatomy and everything about these views change based upon the time we're looking at it and how we're looking at it, and that's why you have to be very good at being a good angiographer. I will say in the United States we have a lot of low volume operators, and that situation is not dissimilar to what happens here in India. And also with radial access, I'm a big proponent of transradial, but the engagement is not as crisp potentially as it might be with other techniques, so you have to work harder to get better pictures. And if you take bad pictures, you're not going to be able to take care of the patient in the best way. Bad pictures equals bad patient care. So in terms of how you do it, well, remember, you have to be selective. The catheter should not kick out during the engagement, and I'll show some examples of these things. You need to have appropriate views with full opacification and without streaming. You want to have adequate radiation. We want to minimize radiation risk, but yet maximize our diagnostic potential. And then you need to stay on long enough to be able to identify not just flow proximally and distally, but even potentially into the collateral circulation as well. So 10 basic pearls for the new student. I think number one, and this is very important when you're engaging the right coronary, engaging grafts, the technique is mostly mental and it's not physical. Everybody focuses on what's happening with the hand, but you have to sort of be thoughtful about it, and you need to control the catheter. Don't let it control you. And for those of you that have done this for a long time, I think you know exactly what I mean. You never want to advance anything, wire, catheter, without fluoroscopy, because that's when bad things happen. You don't want to push against resistance. So if you feel a resistance, or if the patient says, ow, I'm feeling pain, then you want to stop, do fluoroscopy, and make sure you know what's going on. You also want to obtain back bleeding so you don't inadvertently inject air or thrombus. You have to understand what you have in front of you before proceeding, and don't take anything for granted during these cases. I think you want to perform them with finesse, and pain is a problem. And remember to never leave the lab without the answers to the questions posed, unless, of course, there's risk to the patient in the form of contrast issues and the like. So looking at the views to start off with, one of the ways we typically teach this is that the arteries are complementary. So if you have a very large posterior descending artery, you don't need to have an LAD that wraps around the apex. Vice versa is also true. Similarly, for posterolaterals, if you have a huge posterolateral system coming off the circumflex, then you shouldn't have a large posterolateral system coming off of the right. And this is something that you need to piece together in your head as you move on. This is how you'll identify anomalous vessels. This is how, in graft cases, you can identify if you're missing a bypass graft or if something is chronically occluded. You need to basically, for every patient, piece together the whole anatomy with the different views and the different injections, so you can be assured that you've covered all the territories that are supplying that patient's heart. Now, in terms of the actual views themselves, the easiest way to break this down is to look at two planes. One is the RAO plane and one is the LAO plane. So in the RAO plane, basically what you're seeing is you're looking right down the AV groove. So in that circumstance, the right coronary comes towards you and the circumflex goes away from you. And then the LAD system and even the PDA coming off the right coronary, or the left for that matter, goes in the orthogonal plane that way. And this is typically achieved by an RAO 30 shot or anything in the RAO view. The LAO view is orthogonal. What that means is it's directly 90 degrees different. So in that view, the LAD and the PDA come towards you, and the right coronary will come off to the left, and the left coronary, the circumflex, will come off to the right. And so the combination of these views, as well as cranial and caudal, can help you to put together the entire coronary tree. This is sort of a historical figure from the Bayman Grossman book, and I would encourage anybody who's interested in coronary angiography to read the basic chapters. There's some very, very important information in there. Basic pearls, you need to read it once and you'll get it. But the angles are determined by the table position as well as the gantry that you see. Now, why are angles important? Well, there's several things. One is you need to inject appropriately, and the second is you need to get the right view. So this is just an image. There's several things about this that are interesting. One is you see a vein graft off of the diagonal filling retrograde, but you see that the catheter kicks out. So this is not a good injection. The reason it's not a good injection is because you don't get full opacification, even though you do mount enough of a pressure head to fill this vein graft. But this is just a typical AP caudal or RAO caudal type of view. You take the same exact patient in a different view with a better injection, and now you see how severely stenosed the ostium of the circumflex is. This is why it's important to take multiple views when you do angiography and really identify what would in this case be important for the patient. Here's another one where if you look at this view, the LAD typically looks fine, and you can even look at the circumflex in this view. One of the mistakes that many operators make is they only look at the LAD in certain views and only look at the circumflex in other views. You have a free view of the other vessel in the other view, so you might as well look at it in multiple views. This is another view where you see in the RAO caudal that there's something now at the ostium of the circ that looks like something going on, and now here you see there's a severe stenosis at the ostium of the circ. So these are certain basic tips. An LAO caudal, a good LAO caudal, is important to really visualize as distal left main. It's not good though for looking at the mid and distal LAD necessarily, because they're all foreshortened, and I'll explain that in a little bit what that exactly means. But remember to know all the views, the risks and the benefits and the pros and cons of all of these views. The final thing that often happens with students is they sort of say, well, what do I need? So do I need to go for an LAO caudal, 30 and 30, or what numbers do I need? It's not the numbers that are important, it's the anatomy that's important. So typically you want to be on one side of the spine and you want to be able to see what you really need to see. So what that generally means is for cranial views, you want to try to get 35 to 40 at least for the AP cranial, and for these caudal views at least 20 to 30 on each of these, but it may vary based upon the patient and COPD and other things that can change the anatomy. Now, the other thing that you need to remember about angiography is that it is, as a two-dimensional type of modality, subject to artifacts due to eccentricity. So here's just an example of this. If you have a lesion that looks like this, and you're taking a picture this way, you clearly see the lumen has a blockage. The problem is, if you take the orthogonal view, where you look at the lesion, same lesion, just 90 degrees different, you're not going to see any blockage at all because there is lumen from here to here and contrast will fill it. This may appear a little bit hazy or a little bit lighter in opacity than the adjacent segments, but you won't see this view. And that's why you need to take, you won't see this lesion. That's why you need to take multiple views in order to appreciate these lesions. This is illustrated on this series of slides here. This is the screen, this is the artery, this is the X-ray source. If I turn the artery this way, the screen image looks the same. I'm going back and forth here because we're looking at it across. However, if it's eccentric like that and we turn this way, now you see the image projecting on the screen becomes smaller and smaller because we're looking at it in a more eccentric type of way. So this principle is important, and it's why you need to look at the arteries in multiple views in order to determine if there is a stenosis there. And it's also one of the pitfalls of angiography and why we often use physiology to determine if lesions are hemodynamically significant. Beyond whether the lesion is significant or not, we also try to characterize other attributes. Are they at bifurcations? Is it vessel tortuous? Is it in an Ostia location? And other attributes as well. And we also have to be cognizant that it's not just the lesion, it's the flow and the lesion that are important to the patient. So this is just an example of what oftentimes our interventional fellows, they would fixate on this and they fixate on this, but what they really also need to fixate is how the flow comes through the vessels, because those two things together can help determine how to treat the patient. So this is an example of a case that happened in our lab where the interventional fellow takes this first picture, gets disappointed because there's nothing to fix. Well, the reality is if you look at the picture again, sure, there's no clear epicardial stenosis that needs PCI or that ought to be treated, but there's globally slow flow, which is consistent with microvascular dysfunction. We know we didn't do any air embolization or anything like that, but so this is something that could potentially be treated medically. And so in this particular case, we gave nitroprusside and the flow normalizes. So in this case, the interventional fellow should not be disappointed. He should actually be happy because he made a diagnosis in this particular case that the patient had microvascular dysfunction as the etiology of his or her symptoms. Here's another case. This was a case that was referred as a second opinion. This patient had chest pain with ST elevations on injection, and I think you can appreciate down here there's this washout filling defect thing that's sliding back and forth in the vessel. Because the patient had chest pain, the operator got very, very concerned that for thrombus, started the patient on a 2B3A inhibitor, transferred the patient to another facility, and opted to do PCI, ultimately did imaging and did not do PCI. Fortunately, the patient had some other issues going on, and the patient came to me for a second opinion. What this was just the fact that there wasn't enough adequate filling of the vessel. This is not thrombus. This is a normal artifact seen by incomplete opacification of the vessel and blood mixing with contrast in this area. I reassured the patient is doing great 5 years later with no other issues. This is a case where the patient had a pre-op mitral valve replacement. This was the initial angiogram that was done. After the mitral valve replacement, the patient was acutely hypotensive, very, very sick, came back to the cath lab, and the interventional fellow took this picture and said, oh, there's nothing going on because the vessels look okay. Well, the vessel doesn't look okay. There's no clear epicardial stenosis that you see in any of these areas here, but here's the mitral valve ring, and there's an abrupt cutoff of the circumflex right at this location because it was sewed by the mitral valve ring. So it's important to recognize everything that's going on and to piece together the anatomy. You don't see anything filling this area here at all, and that's because this was pinched in this way, and so this was actually opened percutaneously, thankfully. Now, it's also important to remember when we look at stenosis severity that there is an association between diameter stenosis and cross-sectional area stenosis. The reason that we typically consider 70% stenosis diameter to be hemodynamically significant is because if you were to make an area out of it, that corresponds to a 90% cross-sectional area stenosis. A 90% diameter stenosis corresponds to a 99% cross-sectional area stenosis, because you all know how to calculate the area of a circle with basic math. So this is generally why the 70% cutoff has been accepted. The problem with 70% though is that this is all in the eye of the beholder. If you take an angiogram and you show it to an interventional cardiologist and you tell that interventional cardiologist, let's say the stenosis is 70%, you tell the interventional cardiologist the patient is coming in with reflux symptoms and has a normal stress test, they're more likely to call that a 50%. On the other hand, you take the exact same angiogram and you tell the interventional cardiologist this patient has typical crushing angina when they walk 2 blocks and their stress test showed anterior ischemia, that 70% is more likely to be called a 90%. So we have to be a little bit objective in what we do and recognize that there's also subjectivity to this, because even things like nitroglycerin can change what this looks like. So this is the same patient before nitroglycerin, after nitroglycerin. You can see the vessel looks bigger, this picture, and this stenosis, which is maybe a 50% stenosis, kind of goes away here. So that's one of the reasons why many of us have opted to call things indeterminate and then typically use physiology to arbitrate whether it's real or not. And so this is just the same patient before nitroglycerin. You see the lesion here, there's plaque up here, and the cross-sectional area is 3.6. After nitroglycerin, there's still plaque here, but the vessel is dilated, and the cross-sectional area is 5.4. This is another reason why if you're going to call a stenosis severe or not, typically the angiogram is not the best way to ascertain that, or even IVUS is not the best way to ascertain that outside of the left main. What you usually want to do is use coronary physiology to sort this out. Now, other things about the angiogram pitfalls are lesion length. So this view is very easy and straightforward to determine what the length of this lesion is. This view, this may be a little bit foreshortened, but if you wanted to measure this mid-LAD here, it would be very, very challenging. And so many people always ask, well, what is this thing called foreshortening? Why do we call it that? So basically, this is what it is. If you take your hand and you look at the length of your pinky, that length is a fixed length. It doesn't matter whether you look at it this way, or this way, the length of the pinky is the same. The thing is, if you actually change your orientation of your hand, if you turn it this way and you measure the length from here to here, if I'm looking at it this way, it's a lot shorter. Similarly, if I point away, it's a different length. And that's the problem with measuring length on the angiogram, is unless you're directly orthogonal, directly 90 degrees to the actual vessel itself, you will misestimate length based upon the angiogram. So this is just an example of that. This is the LAD, if you want to measure the length here in the spider view versus this LAO view with cranial. And so basically there's a wire that's placed here, and that wire has a fixed length of the radiopaque segment of 30 millimeters, and it looks like 30 millimeters there. But yet in this view, that doesn't look like 30 millimeters. Why? Because it's going away from you and then down. And so if you were to measure length on this image, you would misestimate the length of the lesion. So that's why you want to measure it this way. Other basic pitfalls and tips and tricks: you do not want to inject with a damped catheter. So this is a baseline pressure. This is a catheter in the left coronary artery. If you inject with the catheter looking like this and you just inject steadily, what you get is something like this, where you have a linear dissection extending from the LAD all the way down. In the right coronary, you have a big cusp hematoma because you've dissected back into the wall of the aorta. So that's just basic principles. Just as I said, don't push when there's pain, don't inject with a damped catheter, and make sure that you look at the injection first. Particularly when you work with somebody else who's injecting, they may not look at the picture. So you have to look at the picture, and then you can say go ahead and inject when you're running your own in your lab and you're in charge of what's going on. So I mentioned at the beginning of the talk that catheterization has been typically viewed as the gold standard for triage in many studies. The real question is, can we do better than angiography alone? And that is something that I think is gaining a lot of attention, and certainly at this meeting you're going to see sessions devoted to the use of physiology, also adjunctive imaging, to determine what's going on in a procedure. The reason that's important is because the eye can be deceiving. So this is just a nice slide that I use for a lot of my talks that shows you that these things all look curved, but actually if you plot it out, the lines are straight. It's just the way the dots are oriented that are confusing you. And that comes back to what I mentioned earlier about the patient with a 70% lesion that may be alternatively called 50 or 90 based upon the pretest probability. So how can we get more objective about it? Well, one thing you can do is you can use quantitative coronary angiography. So actually measure the stenosis severity at the normal reference segment, the lesion itself, and then compare those two to derive a percent diameter stenosis. That's not used widely, and the reason is that it's actually still limited by views, and it's also harder to perform online in the cardiac cath lab. I don't think very many people use this outside of clinical trials. But what else can we do? Well, what we can use is imaging and physiology. And in general, when we want to assess stenosis severity, we're talking about physiology. When we want to assess the anatomy, perhaps look at the physiologic significance in the left main, we might be able to use imaging. But by and large, if we're going to determine if something is significant or not, we typically will use physiology to determine that. And there's data based upon that showing that we can safely reduce the need for PCI if the patient has normal physiology in the vessel. That having been said, many people think of physiology as only being used to not stent. Well, in some cases, it actually can show you that there are flow abnormalities in the vessel that otherwise appeared normal. So this is just an example of a vessel. Maybe this is a 50% stenosis angiographically. FFR of this was 0.71. So a 29% reduction in hyperemic flow in this vessel. So in the right patient who might have symptoms, this is something that would be amenable to coronary revascularization. This is another case, though, on the opposite side of it, a right coronary artery that looks severe. It looks somewhat calcified in the mid-segment, and this was a patient that came to me with a normal stress test and a CTA that showed some disease, and he was asymptomatic. When I saw this, and when most operators see this, they're planning for PCI immediately, but because the patient was asymptomatic and had a normal stress test, I did FFR. It was 0.87. And ultimately, because he was asymptomatic with a normal tolerance and normal stress test, we left this alone. The funny thing about this case is that 2 weeks later, he developed a massive retinal hemorrhage and needed urgent surgery. Had I done PCI in this particular case in an asymptomatic individual with a normal stress test and normal physiology, he would have had a major problem with his eye. And as a result, we are fortunately lucky in this kind of case. The thing that comes up for many people, though, is when do I need to do physiology? Should I do physiology in every case? Should I not do it? I get confused, and I frequently get called in our cardiac cath lab as a director by people who sort of say, well, I don't know if I should do FFR or not, or I have this FFR result, I have this IVUS result, I have this stress test result, how do I put them all together? So what I like to say is you generally have 3 inputs into clinical decision making. There's the clinical scenario. How is the patient feeling? How are they presenting? And this is typically for stable disease. I'm not talking about ACS. Then there's non-invasive testing, the treadmill, the nuclear, the stress echo, whatever it is. And then there's the angiogram. And all 3 of these relate to each other and try to paint a picture of the patient. So the question is, when do you want to use physiology? Well, the reason is if all of these things line up, typical symptoms, positive stress test, and a lesion on angiogram, you don't need to do FFR in that situation or physiology. On the other hand, if you basically have missing data or equivocal data or even discordance, so large anterior ischemia and a 50% lesion, you don't want to just stent that because it's 50%. Those are the types of cases where you might use physiology in those types of scenarios. When not to do it, this is an example of a case that was presented to us at one of our fellows courses of a patient that presented with non-STEMI, had this lesion in the vein graft, and because there was some antegrade flow, the operator elected to do FFR of this segment. That you don't need to do. The patient has a non-STEMI, a vein graft that's about to go down. If the physiology by chance is normal, which it was in this particular case, you're going to leave this alone, and that poses a risk to the patient because they're having a non-STEMI. So you have to be thoughtful and always think what you're going to do differently with the results, whether they are abnormal, moderately abnormal, severely abnormal, or completely normal in the first place. Now, other things, just really briefly, limitations of the angiogram and why you might need to do physiology in certain cases, is this type of case here, where it doesn't look like there's any lesion at all, although it is a little hazy. In this particular case, this is what the IVUS showed. The reason that the vessel was hazy was because you would see this plaque in between, but the lumen area across any of these dimensions looks preserved. So sometimes in the acute coronary syndrome setting in particular, you might be misled by just looking at the angiogram alone, and that's why there's increased and renewed interest in imaging for these types of cases. Other areas that the angiogram can be notoriously deceiving is the left main. So here are a bunch of left mains seen angiographically here, some of which look severe, not by IVUS, not severe, yes, severe by IVUS. This doesn't really look severe, yes, severe by IVUS. This looks severe, also severe by IVUS. This looks severe by angiogram, not severe by IVUS. And so this issue comes up frequently, and that's why in general, especially because left main is so prognostically important, we tend to recommend imaging or physiology for left mains in the appropriate clinical scenario. Here's an example of this. This is a patient that was referred for surgery. Somebody took an angiogram, noticed this, and immediately pulled the catheter out because the left main looked severe. This patient was referred for surgery, but there was consideration of spasm. So the surgeon sent them back to us, and when I did this angiogram with nitroglycerin, there was no left main disease there, and we in fact even IVUSed it, and there was zero plaque whatsoever. So yes, you can get spasm of the left main as well as the right coronary too, and this patient was saved having to have surgery that likely wouldn't have had a successful graft. Now, basic pitfalls of angiography, I mentioned some of them earlier. Others include inadequate projections, inadequate opacification, unrecognized left main disease, as I mentioned before, and then other miscellaneous things. So here are just some examples. This is a case where it was quote unquote unable to find the left main. So multiple attempts couldn't engage the left main. A non-selective shot was taken. You don't see anything here at all, but yet when you shoot the right coronary, you see the left main coming off in this way. So the right coronary is occluded and the left main comes off the right side. Anomalies, this should always trigger you. When you see the anatomy but you can't piece together all of the anatomy together, think anomalous. And so this is just an example of anomalous circumflex, a very common abnormality coming off of the right. This is an even less common one that I had a few years ago where everything is coming off the right coronary artery in this particular case. Other things that occur more commonly are dual coronary ostia. This is one that you need to think about, expressly think about, particularly in acute type cases. And the reason I say that is because if you only see one vessel, you may conclude that it's occluded, or you may conclude that it's a different branch. So here's a case, unfortunately, that I had where engagement upon the left main, I assumed that this was the LAD or diag, and there was an LAD, there's a stent here that I was missing over here. Tried for a while to engage it, was not able to engage it. Patient ultimately arrested, they were having an MI, and now when the patient's arresting, you can see, I'll show you here, this is the circumflex, and that's the LAD filling from a dual ostia. So the reason the patient was sick was because they had occluded their LAD stent, but I thought I was in the left main. Instead, I was subselective in the circumflex, and therefore I could never actually wire the LAD. And this patient, unfortunately, was in cardiogenic shock and did not do well as a result. There are other things to think about. This is just an example of right coronary. If somebody shot this very quickly, they would think it's a non-dominant right. It turns out it's not non-dominant. It's just that it's occluded distally. And on the shot of the left, you can see collateral filling of the right coronary. It's one of the reasons why if you see filling of collateralization, you need to stay on the pedal and pan over to really be able to try to recreate the anatomy. Other things you need to be cognizant of are other abnormalities within the vessels. This is an example of a myocardial bridge. Diastole looks okay, systole is compressed. And then finally, moving on to the end of this talk, I'll talk briefly about ventriculography. There are a lot of people who don't do this anymore. I do think it can be very useful in cases, particularly when you have not seen or done the echocardiogram yourself. You remember basically systole, diastole, you can calculate ejection fraction. In general, most of the times it's estimated. But there are other things that are important. This is an example of catheter-induced MR. You might call severe MR on the basis of this, but this was because of catheter position. You can see that you're hung up in the mitral apparatus here. The final thing I will mention is if you're going to do left ventriculography, you want to do it with side hole catheters and typically a pigtail type of catheter. You do not want to do this. This is an example of an end hole-ish type of catheter. Actually, this has even side holes where it's basically injected, perforates through the wall, and you get into the pericardium, and then the operator pulls it back because they see what's going on. So just to sort of summarize, with coronary angiography, this has been a sort of whirlwind talk through a variety of topics, But it's really important to take a step back and to answer and ask the question, what was the clinical question and did you answer it, and did you do so safely? You want to identify important information like what the circulation is, are there any lesions, what's the flow look like, are there other findings? You want to limit contrast and minimize radiation exposure. But in doing so, always remember that you're doing an invasive procedure on a patient. And therefore, if you have no good diagnosis after you do the angiogram, in some respects that should be considered a complication. So you have to make all efforts to try to establish the diagnosis, do it well with good technique, and ultimately that's how you'll be able to help your patients the best. So with that, I'll conclude. Thanks so much.